The patient has got a pseudo exfoliation, hard cataract. Now, the hallmark of the pseudo exfoliation is the accumulation of white or grayish flaky material all around the ocular surfaces. It could be in the iris or the anterior capsule, pupillar margin, and zonal fibers. Anywhere. So there could be some trans-elimination defects, and there could be some pigment dispersals and causing glaucoma. And these accumulation of materials, they cause weakening of even the lens capsule or even the iris zonular ligaments. So a lot of people, they develop glaucoma because of the pseudo exfoliation also. And there are systemic associations, and the patient should be recommended for regular checkups on cardiovascular assessments. So we are talking about the toric intraocular lens. It can be considered for the patient with pseudo exfoliation syndrome. The consideration, what it look for is zonal laxity. Due to the inherent weakness of the zonals in pseudo exfoliation, you have to see whether the zonals are good or not, whether the pupil they are dilating or not, how is the angle, whether there's any abnormality or not, and of course the plate haptics are absolutely discarded. So an intraoperative technique should be more corneal incision should be given, because the pupil is not going to dilate fully, so you have to be a little more corneal. The choppers help at the incision site to prevent the iris prolapse. You have to keep the chopper at that site. I'll just show you in my video. The CTR should be ready, and it will give extra support, but only if there is some laxity of the zonal ligament. The iris retractor, the iris dilators or pupil expanders should be kept ready. Suppose if you have some problem, if the pupil does not dilate fully to your satisfaction. Everybody is expert to their own cases, so that in this case you cannot be able to do it. So be ready with this. Then you have OVDs, and you have the help of dilator to retract the iris while aligning the axis of the toric IOL. So you have to be prepared for addressing the phimosis, and IOL dislocation is essential. If pupil is manageable, a capsule is looking good, and yes, you can go ahead. So if you can put any let's say monofocal. So if you can put a monofocal, you can put a multifocal, and you can even put a toric IOL. Why not toric IOL? So this very small, we did the patient had developed glaucoma, so we did the trabeculectomy pathway. It is a combined operation. You see, I'm giving a more corneal incision. It stopped. So we will see that the pupil did not dilate fully, but then I thought I'll be able to complete the surgery in this, so I did not put any ring or hook or expanders, and the incision were quite corneal. And after doing the trab and not entering the anterior chamber, I started doing the phacoemulsification. The nucleus is very hard, by the way. I generated at 4+++. The capsulexes were done with the help of the Varion, that is the image-guided system, gentle hydrodissection, hydrodelineation, and direct chop method. The nucleus is pretty hard. So I can see that the capsule is so good, stable. So the zonules have passed the test. And then we complete the Emulsification. I always take out my Sinsky hook when I eat up the last chunk of the nucleus. And again, I do the bimanual irrigation aspiration. You can see that the incisions are quite cordial. The patient could not afford the premium IOL, so I put them on economical Toric IOL because I knew that he'll feel better. He will have a vision rehabilitation much better with this. And it was aligned with the help of the image-guided system. And then rest part of the trabeculectomy. And we have more than 6 years of follow-up. The patient reported to us after 6 years. So this was the undilated people, this was the dilated people, and the axis was there where it had put, but little bit of phimosis-like appearance. So lens is stable, so you can put the Toric IOL. There's no problem. Thank you.